Hello, my name is Hector Michelena. I'm an assistant professor of medicine at the College of Medicine at the Mayo Clinic, Rochester, and I belong to the cardiovascular division. We will today be briefly talking about a review article which will be published in the July issue of Mayo Clinic Proceedings entitled Intraoperative Echocardiography in Valvular Heart Disease, an Evidence-Based Appraisal. The reason intraoperative transesophageal echocardiogram has become common practice nowadays is because of its excellent resolution, the variety and different tomographic views that can be obtained, the possibility of doing three-dimensional reconstructions, and of course the possibility of evaluating the ascending aorta for the presence of calcium, which may alter the surgical approach to manipulation and cannulation of the ascending aorta for cardiovascular surgery. Another imaging technique that has been currently recommended as possible standard of care for patients that have high risk for stroke is epi-aortic ultrasound, which is a technique using an ultrasound crystal within the sterile field of the operating table inside the patient, imaging the aorta directly with the probe. So our question was, to what extent does appropriate scientific evidence back up the use of intraoperative TEE and epi-aortic ultrasound in our daily practice? We then realized that the studies supporting the use of intraoperative TEE for valvular heart disease are, in their majority, non-randomized and observational. And most of them are non-consecutive. Nevertheless, we were able to identify 8 studies which we pooled for analysis regarding the impact of intraop transesophageal echocardiogram in valvular heart disease surgery. We found a pooled mean of 4% changes in post-cardiopulmonary bypass period time. In other words, 4% of patients undergoing second pump runs related to post-cardiopulmonary bypass intraop TEE, which compared to mixed cardiac surgical populations is approximately double the amount of second pump runs needed for valvular heart disease surgery than for other indications for cardiac surgery. And importantly, we did not use populations including congenital heart disease for this analysis. In terms of pre-cardiopulmonary bypass findings in intraop TEE that prompted changes to the planned surgery, we found 11% of cases of valvular heart disease requiring changes at the pre-cardiopulmonary bypass stage. It is important to note that the most common cause for a change in the pre-cardiopulmonary bypass stage is the presence of a patent foraminal valve or PFO. Ideally, when one chooses a procedure, one should have data from randomized trials showing that the use of that procedure, which increases costs and may have complications, does improve the clinical outcome of patients. Nevertheless, we have found that there are no important outcomes related studies of intraop TEE for valvular heart disease out there. And for that reason, one has to resort to other means of inference to appreciate the value that a diagnostic technique may have. These other aspects that we looked at include the accuracy of intraop TEE when it has been compared to transthoracic echocardiography and when it has been compared to surgical findings. And in that regard, we find intraop TEE to be quite accurate and acceptable. Another area is the area of cost and the area of complications, and we have found intraop TEE to be of a relatively low cost and with minimal complications. After analyzing the available data for epiaortic ultrasound, we concluded that even though it was scientifically more robust than for intraoperative TEE, the results were somewhat conflicting, and for that reason, in all likelihood, there needs to be further study in the area of stroke protection by epiaortic ultrasound. We believe that this evidence-based appraisal has important implications for clinical policy and for research. And the first thing that it's important is that we believe there is enough indirect evidence to support through inference that intraoperative TEE is a helpful technique likely affecting outcomes, although not proven, in patients with valvular heart disease. We believe that efforts must be concentrated in preventing false positives and false negatives in the use of intraop TEE, and we make specific recommendations in that regard. We believe that certain randomized trials should be performed, including the value in outcomes of reducing less than moderate regurgitant lesions to trivial or none by post-cardiopulmonary intraop TEE. Does that influence the outcomes of patients, or is it a waste of time and a waste of resources? The second one is to randomize patients to intraop TEE and epiaortic ultrasound for detection of atheroma in the ascending aorta and guidance of cannulation during surgery, because it is the only way to know whether there is a benefit from using epiaortic ultrasound versus intraoperative TEE for atheroma detection in the aorta. Finally, I believe that the quality of the science behind our usual clinical practice needs to be revised and examined, regardless of whether it is established common practice. As clinicians, we should look for the appropriate evidence and robust scientific support for the established clinical practice that we perform on a daily basis.
We hope you benefited from this presentation based on the content of Mayo Clinic proceedings. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you're interested in more information about Mayo Clinic proceedings, visit our website at www.mayoclinicproceedings.org. There you will find additional videos on our YouTube channel, and you can follow us on Twitter. For more information on healthcare at Mayo Clinic, please visit www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.